Hello and welcome to Workers Comp Unwrapped, the podcast that simplifies workers' compensation for physicians. So let's get started. Welcome to Season 4, Episode 11 of Workers Comp Unwrapped with your host, Aneeq. And we have our industry guest expert, Angela, who has 15 years of experience in the industry. Today we are talking about how to challenge payer downcoding and modifier reductions.
Yeah, which is, it's just a massive headache for everyone right now.
Oh, absolutely. So we're doing a deep dive into some really fascinating source material on this today. And just to set the stage for you listening at home, I want you to imagine handing over an invoice for a highly specialized, incredibly necessary service you just delivered.
Right.
Like you did the work, the outcome was perfect, and the client took the result. But when they look at your bill, they just cross out the total, write in a lower number, and walk away.
Which is wild.
Right. They don't even dispute that you did the work. They just unilaterally decide that your premium service is only worth a bargain bin price.
Yeah, and in literally any other industry, that's a breach of contract. You'd be on the phone with a lawyer before they even left the building.
Exactly.
But in the medical billing and workers' compensation space, this is just a daily structural reality for providers. It's totally baked into the business model of the payers.
Which is exactly the mission of our deep dives today. We're looking at a whole stack of transcripts and industry source material that just lay out the harsh realities of revenue integrity.
Unpack the mechanics, really.
Yes, the goal here is to unpack the actual mechanics behind why your claims get reduced, specifically through payer downcoding and modifier reductions. And then we want to give you a strategic blueprint for fighting back.
Because medical practices are just hemorrhaging money that they actually earned.
Right. And the mechanisms causing it are far more sophisticated than like a grumpy insurance adjuster sitting in a dark room with a red pen,
Oh, totally. That red pen is completely gone. It's been replaced by lines of code.
Yeah.
The sources make it super clear that downcoding isn't typically a manual human decision anymore. It's the result of these systemic automated blanket reductions. Payers use these incredibly complex algorithms designed to ingest millions of claims and just automatically flag them based on really rigid criteria.
So let's break down that mechanism a bit, starting with downcoding itself. Because this is basically when a payer actively reduces the level of service billed.
Yeah.
Like a provider submits a claim for a high-level evaluation and management code, an E&M code, because the patient had complex needs requiring a lot of time and medical decision-making.
Right. They did the heavy lifting.
Exactly. But the algorithm catches it and reimburses it at a much lower basic level. It's essentially like an aggressive automated spell checker.
Oh, I like that. Explain that a bit more.
Well, imagine typing a highly technical, complex engineering report, right? But your word processor has this aggressive autocorrect with an intentionally limited dictionary.
Okay, yeah.
So it constantly changes your specialized, complex terminology into standard, like fifth-grade vocabulary.
Oh, yeah.
And then the client refuses to pay your premium engineering rate because the final report looks like a fifth grader wrote it. The algorithm is retroactively forcing your complexity into a standard box.
That is a perfect analogy. And you have to realize it's a highly profitable autocorrect. We have to look at the economics driving this from the payer side.
The money, yeah.
Right. Payers rely on something called the attrition rate. They know that if their algorithm automatically downcodes, say, 10,000 claims, a massive percentage of those providers will just write off the loss.
Wait, really? Just give up?
Oh, absolutely. Sometimes upwards of 80% of them, because they don't have the staff, the time, or the energy to appeal.
Wow.
The algorithm doesn't even have to be right every time. It just has to be exhausting to fight.
So it's completely a volume game. They win by making the process as painful as possible.
Exactly.
So if these algorithms are doing this blindly at scale, what exactly is triggering them? Like, what are they targeting? Because the sources heavily point to evaluation and management levels as kind of ground zero for this.
Yeah, E&M codes are the bread and butter of almost every medical practice. They represent a massive chunk of billing volume. But the criteria separating, a level 3, a level 4, and a level 5 visit are incredibly nuanced.
It's not just a matter of how long you spent in the room.
Not at all. It comes down to medical decision-making, or MDM, like how many diagnoses were managed, how much data was reviewed, what was the risk of complications.
Right. So if a doctor evaluates a patient with 3 interacting chronic conditions and prescribes a new high-risk medication, that is a highly complex visit.
Absolutely.
But if the doctor's clinical note just says, patient seen, medications adjusted, return in a month, the algorithm sees literally zero evidence of that complexity.
It sees a level 2 visit, period. Because these algorithms are just scanning for explicit documentation elements, specific keywords, bullet points, structured data that quantifies that MDM. If the note is brief, the algorithm instantly triggers a downcode.
And that triggers the golden rule of medical compliance, which we all know and kind of loathes, right? If it isn't documented, it didn't happen.
Yep.
I mean, this is day one stuff for anyone in revenue cycle management. But what the sources highlight that's really controversial is how payers have weaponized this basic rule using AI.
Weaponized is definitely the right word, because in the past, a human auditor might read a slightly messy note and infer the complexity based on clinical context, right?
Give the benefit of the doubt.
Exactly. Algorithms do not infer. They don't care about context. Your clinical note is the only bridge between the medical reality and the financial reality.
Wow.
And if it lacks explicit structural proof of complexity, the payer system just instantly capitalizes on that vulnerability.
Well, let me push back on that a bit on behalf of you listening. Wait, if a doctor genuinely performed a complex procedure and the patient was successfully treated, why does a slightly messy or brief clinical note mean the doctor shouldn't get paid?
It's frustrating, I know.
Shouldn't the actual treatment carry the weight? I mean, they fixed the patient.
Morally? Sure. But this is the harsh reality of medical billing compliance. Payers legally cannot verify the complexity of the treatment without explicit written proof.
So it's a legal shield for them.
Completely. Making airtight documentation isn't just a medical necessity anymore. It is a strict financial one. Which brings us to the other massive target painted on the backs of providers. Modifiers. Specifically, modifiers 25 and 59. Our source materials emphasize modifier reductions just as heavily as E&M downcoding.
Yeah, and this is where the mechanics get even more granular and, frankly, annoying. So break down why modifiers are such a bullseye.
Well, modifiers are critical because they tell the story that a visit wasn't just, an out-of-the-box standard encounter. They indicate significant complexities or that multiple distinct procedures were performed.
Right.
Modifier 25, for instance, is used when a significant separately identifiable evaluation and management service is performed on the exact same day as a minor procedure.
Okay, so let's give a practical example. A patient comes in for a scheduled steroid injection in their right knee. That's the minor procedure.
Yep, straightforward.
But while they're sitting in the room, they say, "Hey, doc, can you look at this brand new, severe, radiating pain in my left shoulder?"
A classic clinic scenario.
Right. So the doctor has to do a full evaluation of that new shoulder problem, come up with a treatment plan, and then do the scheduled knee injection.
Correct. So the doctor legitimately performed two completely distinct services: the shoulder evaluation and the knee procedure.
Two things.
Yes. And to get paid for both, they append modifier 25 to the E&M code. But here's the controversy. Payers absolutely hate modifier 25.
Because it fundamentally increases reimbursement.
Exactly. It forces them to pay for two things on the same day, which they despise.
So how does the automated algorithm catch and deny it? What's the mechanical trigger there?
Most often it comes down to diagnosis mapping. The algorithm is looking at the ICD-10 diagnosis codes attached to the claim. If the doctor uses the generic diagnosis of joint pain for both the knee injection and the shoulder evaluation, the algorithm just instantly flags it as duplicate work.
Oh, I see.
It just assumes the E&M visit was standard preoperative prep for the injection, and it outright denies the modifier 25. The extra work is completely wiped off the invoice.
Because the algorithm sees the exact same diagnosis code and concludes, "Oh, you're trying to charge me twice for treating joint pain."
Precisely. The only way to bypass that trigger is to map the distinct diagnosis of the shoulder to the E&M code and the distinct diagnosis of the knee to the procedure code.
Proving to the machine that these were entirely separate issues.
Yes, proving it mechanically. And that takes really meticulous coding and documentation. But let's look at the reality here. Even when a provider does map the codes perfectly,
Right.
even when the documentation is absolutely flawless, these automated systems will still frequently reduce the claim.
Wait, even if it's perfect?
Even if it's perfect. The parameters are often set so aggressively by the payers that legitimate claims are just swept up in the dragnet anyway.
That is infuriating. So if the algorithms are catching everything, and even perfect notes aren't enough to stop the denial from happening in the first place, what do you actually do when the explanation of benefits, the EOB, arrives and the money is just already gone?
That's when you transition into a tactical counteroffensive, and it really starts with how you view that explanation of benefits.
Don't just accept it.
Exactly. Never accept it at face value. An EOB is not a final verdict. You have to treat it as the algorithm's opening negotiating position.
So you're looking for the exact mismatch. When you see a denial or a reduction on the EOB, you can't just, throw your hands up and complain. You have to locate the specific denial code the payer used.
Yes, play detective.
Like, are they claiming lack of medical necessity? Are they claiming the modifier was invalid for that specific CPT code combination? Exactly what rule are they citing?
You take their cited reason and you hold it up against your own clinical documentation and the official coding guidelines.
Find the logic error.
Find where the algorithm broke. Because once you isolate that error, you have the structural foundation for your appeal.
I really want to focus on the actual anatomy of that appeal, because the source transcripts are adamant about what does not work.
Oh yeah, people make huge mistakes here.
Right, because I imagine a lot of frustrated providers just want to write back, hey, I performed the work, here are the notes, pay the damn claim.
Which is totally understandable, but it's an emotional response and it goes straight into the trash at the payer's office.
Yeah.
Saying, we disagree with your assessment is a complaint. It's not an appeal. A successful appeal is a highly structured, relentless legal argument.
Because a human is finally looking at it.
Yes, and that human reviewer's primary goal is to find a reason to maintain the denial.
Of course it is. So what does the text of a winning appeal actually look like?
It leaves literally zero room for interpretation. You explicitly state the denied code and modifier. You quote the specific official CPT coding guideline that proves your usage was correct.
Give them the rule book.
Exactly. Then you directly quote your own documentation. You might write, in accordance with CPT guidelines, Modifier 25 is appended to E&M code 99214. The patient presented for a scheduled joint injection, but during the visit, a distinct medically necessary evaluation of a new shoulder impingement was performed.
So you spell it out perfectly.
And you tell them exactly where to look. Please refer to paragraph 2 of the history of present illness and paragraph 4 of the medical decision-making, which clearly detail the separate evaluation.
You are leading the reviewer by the nose to the exact sentence that forces them to pay you.
Yeah.
And then you bundle that with the receipts, right? The progress notes, the operative report.
You give them a package that is undeniable.
Okay, but let's look at the operational reality of this for a second. Building a legally airtight, guideline-citing, highly structured case for every single arbitrarily downcoded claim that sounds like an operational nightmare.
It is.
Right. I mean, a busy practice or a stretched thin billing department would completely drown in the sheer volume of this appeal paperwork.
Yeah.
How do they not just sink?
Well, this brings us right back to the attrition rate we talked about. Payers count on the fact that you will drown.
They want you to give up.
They know that creating a bespoke, meticulously crafted appeal takes 20 minutes. And if they deny 1,000 claims, you simply don't have the man-hours to vet them all.
Especially considering the timely filing limits, right? The clock is always ticking.
The second that EOB is generated, the timer starts. You often have strict deadlines, sometimes 60 days, sometimes less, depending on your specific contract to file that appeal.
And if you miss it?
Miss the window by a single day, and the revenue is permanently forfeited. It doesn't matter how perfect your documentation was, it really is trench warfare.
Okay, so fighting claim by claim in the trenches is obviously vital. But as a long-term business strategy, it's totally unsustainable. Like, you can't out-appeal an algorithm. The volume will eventually crush you.
Exactly.
So how do organizations shift from being reactive, constantly putting out fires, to proactively preventing these claims from being reduced in the first place?
You have to fix the process upstream. And the primary mechanism our sources point to for achieving this is internal auditing.
Oof. Okay. Internal auditing sounds like inviting the IRS into your home voluntarily.
Right.
It has a very negative, compliance-heavy connotation for a lot of providers.
It feels daunting, but it is deeply empowering because it actually hardens your defenses.
Yeah.
An internal audit isn't just checking boxes, it's a proactive stress test of your revenue cycle.
So you don't wait for the payer.
Exactly. You don't wait for the payer to tell you your notes are weak. You find out yourself.
Let's walk through the mechanics of that. What does a useful internal audit actually look like on the ground for, say, a smaller practice that doesn't have a massive compliance team?
A really common method is a probe audit. You pull a random sample of, say, 10 to 20 charts from a specific provider.
Okay.
But you look only at the text of the clinical note, completely blinding yourself to the codes the provider actually billed. You essentially act as the algorithm,
Oh, that's smart.
based strictly on the written words in that note. What level of service would you code? What modifiers are explicitly supported by the text?
Then you compare your blind coding to what was actually billed on the claim, and you look for the gap.
Precisely. If the provider billed a level 4 E&M, but the documentation only supports a level 3, you have a massive problem. But now you know exactly where the leak is before the claim ever goes out the door.
You're identifying the specific vulnerabilities the payer algorithms are going to exploit.
Exactly.
And once you identify those vulnerabilities, how do you fix them? Because telling doctors to just document better is notoriously ineffective. They're busy.
Very ineffective. Because free text documentation is the absolute enemy of algorithmic compliance. Every provider writes differently.
Right. Some write novels, some write 3 bullet points.
Exactly. To survive algorithmic scrutiny, you have to remove the variance. You implement standardized templates embedded directly into your electronic health record.
So you force the compliance through the software itself.
Yes. If your internal audit shows that Modifier 25 is constantly being denied because providers are forgetting to document a separate diagnosis,
Yeah.
you build a hard stop into the EHR template. The system literally will not let the provider close the chart and bill the modifier until they have filled out a specific narrative box detailing the distinct, separately identifiable service.
Wow, so it takes the guesswork completely out of the provider's hands. It's like fixing a leaky pipe instead of just constantly buying more buckets to catch the water.
Oh, I love that analogy. It's exactly that. You're starving the algorithm of the ambiguity it needs to trigger a downcode. And even a minor change like enforcing a new template can dramatically drop denial rates overnight.
That's huge for small practices. But beyond the templates, the sources mention another strategic lever that feels almost aggressively analog in this era of AI-driven billing.
Picking up the phone.
Literally calling them.
Direct payer engagement. Because if your internal tracking reveals that one specific payer is suddenly downcoding a specific procedure across your entire practice, you aren't dealing with a documentation issue anymore.
Right, it's a pattern.
You are dealing with a systemic payer policy or a glitch in their algorithm.
And appealing those one by one is just useless.
It's throwing pebbles at a brick wall. That is when you elevate it. You bypass the standard appeals portal, you engage your provider representative, or you request a peer-to-peer review with the payer's medical director.
Just skip the machine entirely.
Yes.
Yeah.
You present the trend data. You say, look, your system has downcoded this specific CPT code 400 times in the last month, despite our documentation perfectly matching national guidelines. We need a global resolution.
And does that actually work?
Surprisingly often, yes. A single conversation at the structural level can clear a logjam that 1,000 individual appeals would never fix.
So, synthesizing all these strategies detailed in our source material today, the mandate for you listening is extreme vigilance.
Without a doubt.
You have to operate under the assumption that the algorithms are aggressive, inherently biased towards saving the payer money, and frequently wrong in their application of coding guidelines.
The days of submitting a claim and just trusting the system to reimburse you fairly are completely over. It's an adversarial process now.
It really is.
You must systematically review your EOBs, perform those brutal internal audits, standardize your clinical templates, and construct your appeals as irrefutable legal arguments.
Because look, you do the grueling work of healthcare. You absorb the risk, you carry the overhead, and you deliver the outcomes for the patients.
You earned that revenue.
Safeguarding your revenue integrity isn't just some administrative chore. It is the only way to ensure the financial sustainability of your practice.
It guarantees you actually have the resources to keep the doors open and continue serving patients tomorrow.
Absolutely. I want to leave you with a final thought to mull over, something that pushes the boundaries of the source material we covered today.
Okay, let's hear it.
We spent this entire deep dive outlining how payers use algorithmic systems to ingest millions of claims and execute massive machine speed denials, right? They rely on the sheer volume of those denials to exhaust human billing teams.
The attrition model, yeah.
Right. But we're currently witnessing the rapid deployment of incredibly sophisticated AI agents on the provider side as well.
Oh, interesting.
Think about it. Tools that can ingest an entire patient chart in milliseconds, instantly audit the clinical note, dynamically format the claim to bypass known payer algorithms.
Fighting fire with fire.
Exactly. And when a denial does happen, the AI automatically generates that perfectly cited, evidence-based appeal letter the exact instant the EOB hits the portal.
That changes the game completely.
It's the ultimate technological arms race. So the provocative question to ask yourself is this. As this technology scales, are we heading toward a future of entirely automated algorithm versus algorithm billing warfare?
Wow.
Where the payer's AI tries to blindly downcode the claim, and your AI instantly and relentlessly fires back the perfect appeal thousands of times a second.
Just machines yelling at machines.
Right. And if we reach a point where human beings are entirely removed from the mechanics of medical billing, who actually wins when machines are the ones negotiating the ultimate value of human healthcare?
That is a wild thought to leave on.
Something to think about. Keep your documentation tight, hold the line on your revenue, and we will catch you on the next deep dive. Thanks for listening to Workers Comp Unwrapped. If you found value in today's episode, subscribe and share with fellow doctors. Stay informed and keep making a difference in your patients' care.